Hi there, everybody. Good morning or good afternoon, depending on where you're logging in from. Thank you for joining us today for this presentation of personal injury and ICD10, which we've run before and turned out to be of pretty keen interest to our attendees. So we've made the event available again, and we appreciate everyone joining us. We understand that ICD10, of course, is now upon us, and whether you are interested in personal injury practice, whether you are already in the business of personal injury, we understand that that is of importance to you. So, of course, today we have enlisted the kind assistance and guidance of Dr. Scott Tauber, who will be our presenter today. He is the COO and Chief Presenter of AIPIP, the American Institute of Personal Injury Physicians, and over the next hour we'll be talking about some of the best practices for personal injury care or documentation and how ICD-10 relates to that. We like this to be a very interactive presentation, so as we go through you may notice that we have a chat pod where you can interact with us and with each other. We're also going to have a Q&A pod that some of you may have noticed during the beginning, where you can talk about some of your questions. We will allot some time at the end of this for questions and answers. Whatever time we have. If we don't get to you by the end of it, we want to pick up with you and make sure that that gets done. So I guess other than that, if there's anything that we can assist you with, feel free to let us know in the chat. And other than that, I will turn the time over to Dr. Tauber. Actually, I think I need to unmute him so he can actually talk here. So let's do that real fast. There we go. So Dr. Tauber, you should be okay.
Yep. Can you hear me?
Sure can. Yep. So I'll go ahead and turn the time over to you, and if there's anything that we can do for you, just let us know in the chat. Thanks, everybody.
Okay. All right. Thanks, Jeremy. Appreciate that. Well, thank you, everyone, for taking time out of their day for participating in this webinar. I also want to thank JTech for hosting and presenting this webinar as well, and thanks to Jeremy for all his help behind the scenes, and Mary for all of her help in putting this together to get you the information on ICD-10. And specifically today we're going to talk about how it relates to your personal injury practice. So I'm going to go ahead and move along here. So today we're going to talk about personal injury and ICD-10, the potential impact to your practice. But before we get into the presentation, I just want to tell you a little bit about AIPIP, the American Institute of Personal Injury Physicians, who we are, what we do. Some of you, this may be the first webinar, first time you're hearing our name. Some of you may have been on previous webinars, maybe even attended some of our live seminars that we do around the United States. But AIPIP trains providers of all specialties. Doesn't matter if you're a DC, MD, NMD, PT, DO, NP, whatever initials you have at the end of your name. If you're interested in improving your personal injury practice, if you're interested in protecting your cases and learning how you can protect your cases better, how to expand your PI practice, and then ultimately how to market that to get more referrals, that's what we do at AIPIP. We help to shorten the learning curve and help you navigate through the landmines of personal injury, and many of you know there's plenty of landmines out there, so you can start getting results sooner. So it takes you a lot less time to get where most providers want to get to, is seeing more patients, increase revenue, increase referrals, and taking less time to do so. You should know that the information that we provide and that we deliver at AIPIP is practical. It's no theoretical information. The resources are tested, the materials that we provide are relevant. We also have tools that you can apply directly into your personal injury practice. So that's a little bit about who we are and what we do. As far as who I am, just to give you some context, I graduated in 1984. I practiced for over 20 years, and so I know exactly what it is to be in your position in the trenches every day, working on personal injury, trying to figure out what's going on, how do I get paid, how do I get more of these types of patients, all that good stuff. And during the time that I was in practice, I actually began consulting and started consulting with providers. Eventually, I started to consult with the auto carriers, and I won't name who they are, but you would recognize their names, obviously. You see their television commercials. Pretty much everyone that's advertising on TV was a client of mine for a period of time. And what that did, it gave me some really great insight into what the carriers wanted and what they were looking for. So it really wasn't until after I was out of practice that I started to see what it is in personal injury, speaking to attorneys very openly and frankly, working with the auto carriers, because they certainly don't share this with you while you're in practice, and none of us learned it in our professional training. So I've also spoken at state association events and been published in some state and national journals as well. So let's go ahead and get started. So it is upon us, whether we like it or not. ICD-10 is here starting as of October 1st. And there's a lot of confusion, there's a lot of uncertainty, and there will be a lot of scrutiny as well, at least in the personal injury environment. We've gone from approximately 17,000 ICD-9 codes up to 68,000 ICD-10 codes. There's a lot of specificity, there's a lot of detail going on in these new codes. Now, as far as the auto carriers are concerned, it is voluntary whether they choose to use ICD-10 or not. So carriers for a while may accept both ICD-9 and ICD-10. There are some carriers that have openly expressed that they will start to accept ICD-10 right away. And then there's others that are just kind of putting their toe in the water. But here's the bottom line, people. Here's the deal. If the carriers don't accept your ICD-10 codes right off the hop on October 1st, pretty much guaranteed within 6 to 12 months, all the insurance carriers, all the auto carriers will be accepting them. So when it comes to the carriers, they're, like I said, they're not really open about it. Some states may be a little bit different, but the recommendation here is to go ahead and start using ICD-10 no matter what. So ICD-10 is a little bit different than ICD-9 as far as we're using what's called a tabular list, and I'll show you where to get one if you don't have one already, which hopefully you do, but I have been hearing from some providers that don't have anything in place related to ICD-10, which I just find hard to believe. It's not as if this has snuck up on anyone. This has actually been in the works for the last 5 years. And every year it's been postponed, and this year we made it all the way to the finish line. In ICD-10, we have this thing called laterality. We have a right and left when it comes to diagnoses. We didn't have that in the ICD-9, so it's a little bit more specific that way. It's specific as far as episodes of care, and we'll talk a little bit more about this and what those letters mean and how to get to those letters. There's dummy placeholders there, which wasn't in ICD-9, and there's seventh digit extenders in order to get out to certain codes that do require a 7th digit. And we have the external cause codes, which are the old E codes, like the E812.0 driver of an automobile accident. And this is where a ton of codes are located and where you're going to really get specific if you're doing any personal injury. Let me just say this about personal injury. Many of you and many providers don't actively seek personal injury patients. I know some of you don't market, don't do any internal marketing to your patients, don't try and market to any PI attorneys, but just by the natural patient base that you have, unless you actually physically turn personal injury patients away, people that you've treated for other types of conditions and maybe have seen you as cash or health insurance will come to you. And so by default, you're going to be treating personal injury patients. Here's the issue though. Once you get into treating personal injury patients, you are held to the standard and should know everything related to personal injury, the same as somebody who actively pursues personal injury. Because if you don't, your records, your bills, everything is going to be scrutinized just the same. And it doesn't matter, well, oh, I didn't actively pursue personal injury. Does not matter. I've spoken to so many attorneys that have said, you treat one personal injury patient, you might as well be treating all personal injury patients, because everybody in the med legal arena assumes you know exactly what to do and do it correctly. So it doesn't really matter if you're out there promoting or not. Now, this is the tabular list that I had referred to. If you don't have it, you can download it from the CDC website. There it is right there in red for you. And this is interactive once you do download it from cdc.gov with all the slashes and all the numbers and letters in there. These blue sections right here will become interactive, and these are now chapters. So we have 21 chapters right here. Now, we're not going to use all of these chapters in personal injury. In fact, in your personal injury practice, you're going to get about 80 to 90% of your codes from essentially 4 of these chapters. And that would be Chapter 6, Chapter 13, Chapter 19, and Chapter 20. Now, for the rest of your practice, I don't know, depending on your specialty, you might be using all of these chapters. Now, I'm just talking about personal injury, so I would say safely about 90% are going to come from those 4 chapters. So we have Chapter 6, which is diseases of the nervous system. Chapter 13, diseases of the musculoskeletal system and connective tissue. Here are a couple that you might, I put in there, these are not part of the 4, but you might have something going on in there. You may have a patient with a congenital malformation, so that's something that should be diagnosed. And then, as I said earlier, Chapter 19, injury, poisoning, and Chapter 20, which are your external cause codes. All right, so let's talk a little bit about details. ICD-10 is going to be all about the details, the level of detail that you can produce that can support the increased specificity related to ICD-10 and the scrutiny that's going to come along with it. So I find this quote kind of appropriate for what we're talking about, even though it's by Giorgio Armani, and he's a famous fashion designer, as many of you know. To create something exceptional, your mindset must be relentlessly focused on the smallest detail. And I just found that that perfectly dovetails right into what ICD-10 is all about. Details, specificity. Now, for many of you out there, you know, your details, if you thought the details were hard already in personal injury, it's going to ramp up even more because of the level of detail that's related to these ICD-10 codes. And so that's where I want you to start focusing on, and we'll talk about that in just a second, and things that you can actually do to increase the quality and level of your details. So documentation, obviously many of you already know that your documentation can benefit from some sort of improvement, and auto carriers certainly don't tell you what to do, and that's kind of what we're trying to accomplish here today. But documentation is going to be critical in ICD-10. Shocking, right? As if that was something you didn't expect. You should already know that your personal injury cases are already, even before this, highly scrutinized. So this may be new to you, maybe you didn't know, but auto carriers already watch everything that you do. They already have national databases on every single one of your personal injury cases. They already know who the attorneys are on those cases. They already know what they settled for. They know who the treating physicians are. Shocking to many of you maybe, but you know, your cases are watched and monitored and scrutinized. You must have a clinical rationale for pretty much anything that you do, and you certainly are going to need it for your ICD-10. There's going to be a big difference in the diagnoses. Again, you must become detail-oriented, and I will tell you this, that in order to really have success, I recommend that you focus on the first office visit and really nail down all the elements of that initial patient visit. So where does your diagnosis come from? Well, you don't pull it out of thin air. It comes from your clinical rationale and your supporting diagnosis, or your supporting documentation, pretty much on the initial office visit, your history, your exam, your diagnostic imaging, all of these things ultimately lead to the code that you're going to choose for your new ICD-10. So that's why the initial office visit is so important. So it all comes down to having a strong visit documentation and laying the foundation and support for everything to come after that. So we already know that the insurance carriers are watching. So first party, patient's own insurance, if you're billing MedPay or PIP, or if it's a UM or UIM case, they're watching. If it's even a PI case, but maybe you're billing health insurance, they're watching. Obviously, you know, these are the patient's own insurance. For those of you that are new to PI, the first party is your patient's own insurance carrier. The third party is also watching. The person at fault or the at fault carrier is watching as well. You already know in personal injury, not only are your cases highly scrutinized, but every case is scrutinized, right? Every case you have to send your bills and records, which is unlike any other of your financial classes. You don't send your bills and records to somebody on cash. You don't necessarily send your bills and records, you know, to certain health insurance carriers. So with a personal injury, everybody is looking at your records. Now we have the third party. So who's involved in the third party? We have claims adjusters, defense attorneys, records reviewers, which is what a lot of what I did a lot of for the auto carriers, and IME doctors. With each person that's looking at your records, if you don't have clinical rationale to support your ICD-10 diagnoses, you allow them to begin to chip away at your bills and slash and burn the bills and also deny treatment. Just to give you an example, you know, the old diagnosis was 847.0 cervical sprain strain, and nobody kind of knew what it was. It could be a sprain, could be a strain, it could be both. Who knew? Here's 847.0, I'm billing it, go have fun, you guys figure it out. Well, that doesn't hold anymore because in ICD-10, we have two separate diagnoses, one for sprain and one for strain. And so the treatment duration and frequency and healing period is very different, as you know, for a strain versus a sprain. And if your clinical documentation only shows that the patient had a strain, a muscle type injury, but you diagnosed and billed all your treatment with a sprain, and then your records are reviewed and they see that it doesn't match, well, they may decrease your payment. They may ask for recoupment. They may do a lot of different things. Here's the deal, folks. It's in the insurance carrier's best interest to use ICD-10 because it allows them greater scrutiny. As I mentioned earlier, documentation issues, not surprising for whatever profession, and especially related to personal injury, because nobody tells you the rules. So, you know, we kind of do what we think is right, but the insurance carriers will get in there at some point, whether it's first or third party. Who else is looking at your records? Well, plaintiff attorneys, so the patient's own attorney will be looking at other physicians that may or may not be involved in the case, judges, juries, arbitrators, mediators, possibly state boards, malpractice carriers. The bottom line here is basically everyone in personal injury is looking at your records or has the opportunity to look at your records. Very different than what you're used to in the rest of your practice. So if this is kind of scaring you and you think, oh my God, you know, this is really frustrating, aggravating, I don't even want to do this. Well, in life, we always have alternatives. So this is what I'd recommend that you do. If you don't want to go forward with ICD-10 or the rest of the webinars, grab yourself a frosty drink in the remote and curl up on the couch, and life will be good. But for the rest of you that have to keep going, we have some more information for you on what you can do in your practice. So the auto carrier scrutiny is there. They're going to look at your treatments. They're going to certainly look at your clinical rationale, which is your underlying supporting documentation for your treatments, the supporting documentation, your examination details, and we'll talk about the exam here in just a second. Objective findings. What is truly objective? I want you to start thinking about that. Jot that down. Focus on objective findings. And then ultimately, what's going to be your diagnosis? All right, Jeremy, can we get up a quick question out there? Yeah, just
Sure.
take a few seconds, guys. Thanks. What percentage of your current personal injury practice, or what percentage of your practice are personal injury patients? Take a quick second just to kind of give me a feel of who we're speaking to today. Thank you. Can I keep going, or do I need to wait for that?
We can do it either way. You can wait, or we can move it off to the side either way.
Yeah. I'll just wait. Yeah, just go ahead and. Okay, so we are all over the board on this. Really, we have a lot of people that don't do a lot of personal injury. I would say more than half of the group here is less than 25%. So, and that's difficult. You guys have it the hardest, because when you don't do a lot of something and now a patient comes in, it's hard to remember all the moving pieces and exactly what to do. If you do something 100% of the time, of course, you have your systems and your practices and your procedures down. So actually, for more than 50% of you, personal injury might be a little bit frustrating, aggravating, and difficult because you don't do a lot of it. Some people think, oh, personal injury is easy because I don't do a lot of it. It's just the opposite. So here's an example of some auto carrier scrutiny, and this was an actual letter that's sent to me by one of the carriers, and this is what they want to know about doctors' treatment and diagnostic studies, and reasonable and necessary. Do you feel that the treatment to date and or the diagnostic studies have been reasonable and necessary? And where do you think that information is going to come from? If this is sent to me to review one of your records, and this is sent to me by an auto carrier, where do you think I'm going to look? Well, I need to look at your records, right? Just to let you know how often they use this form. You see how it's kind of slanting from left and it's going downhill to the right? That's not me scanning it in. That's the actual letter directly from the insurance carrier. That's how often they use this. And so they make copies of a copy, and they don't really care. They just send this out. So, so where am I going to look? And a lot of doctors think, well, I'm protected. I've got this fancy EMR that I spent $10,000 on, or maybe I got it free, you know, and somewhere in between. Well, I have an EMR. It's going to protect me. This is not going to protect you, this level. So just because you have an EMR and you can press some buttons and print out, this is not even nice, but print out a nicely typed treatment note, is not going to protect you. And you know, I get questions all the time about EMR. I'm not going to go down that path, but let me just tell you this about EMRs, that no matter which one you have, you do have to spend some time with it and customize it for your practice, because they're not going to be helpful for you right out of the box. Now, the auto carriers, as I mentioned, it's in their best interest because it's going to be able to track the providers. There's such increased level of detail that you need to be able to support your diagnoses, your treatment, and everything else, that it's going to help the auto carriers track you. So based on a certain set of codes that you use, sprain, strain, or both, and other codes as well, which providers are actually more efficient? It's going to get easier to track providers' efficiency And don't think that that's not what they're going to do. It's all about tracking and keeping an eye on everybody. And so they're going to say, okay, you fall outside the scope or the standard. I mean, we'll probably see this as it kind of, the dust settles on ICD-10 in a few years. We'll start to see some of these reports coming out, and you might actually see some of them from the auto carriers. Claims denial. PIP and MedPay. It's going to make it easier to deny PIP payments, MedPay payments, because if your treatment is not reasonable and necessary, if you're not supporting your diagnoses, we don't have to pay. So it's up to the provider to prove that your treatment is reasonable and necessary, as you saw in that example with the letter from the insurance carrier. And the first place any reviewer or any claims adjuster or anybody looking at your notes is going right for your documentation. Here's the bottom line. It always comes down to documentation. I know you don't want to hear that. I know it's not the sexiest thing. I know it's not why you went to school, whatever your profession is right now. I know all of that. But no matter what, whether you want to get paid, whether you want to protect yourself, whatever it is, it all comes down to what is the level of your documentation. And the third party is going to be looking at it, as we know. And this may be a new term for you called recoupment. This is where you get your checkbook out and you write a refund check back to the auto carrier. Now, they don't do this right away, but sometimes providers get letters and say, hey, you know, send me these 5 PI patients. And it could be a year, it could be 2 years after you saw this patient. What do you think they're going to do? Especially on the PIP and MedPay side, and maybe on the third-party side too. So they paid you, let's use a nice round number. Say you billed $10,000 in PIP and you got $10,000 in PIP. 2 years later, you get a letter from the insurance carrier and you got $10,000 on each one of those. And they say, send us these 5 patients. They actually start going through and they say, okay, these are the diagnoses that they use. This is the documentation that this provider has. It doesn't really support this level of frequency and duration, and the treatments therefore are not reasonable and necessary. Hey doc, why don't you send us a check back for $30,000 because we determined that, you know, your documentation based on your diagnoses and everything else didn't support this treatment. How many of you are ready to write a check for 30 grand? This is what has the potential to happen in personal injury. So it's not just this panacea of, oh, right, great, we're going to submit the claims. There's a method to the madness. Again, my opinion, having been in there, that the insurance carriers are doing this. They're going to look for the low-hanging fruit. So who's the low-hanging fruit? People that have poor documentation, poor management, people that maybe even not knowingly send flares and red flags to the insurance carrier because they don't know what to do in personal injury. And basically they're saying, hey, come investigate me. So moving forward, we'll go after the low-hanging fruit at the end of the day. Haha, it's always funny until somebody gets a letter from an insurance carrier, right? It's all fun and games. So let's get into what we can do. And remember, we talked about getting a better first visit. So I'm going to focus on the examination component of the first visit. Obviously, there's diagnostic imaging and there's history, examination. All of this will ultimately lead to a diagnosis. These are the items that you can include in your personal injury examination. And in fact, I would highly recommend that you do all of these. I know many of you out there going, are you kidding me? Really, Scott? I got to do this? Well, within there's a lot of objective findings that can be had. Not only doing these will support your billing code, your E&M code. Just to take you even a step further back, you are treating acute traumatically injured patients, so I would assume you want to protect yourself and not injure anybody and do something that maybe a patient has a fracture or dislocation and you're maybe didn't do a thorough enough exam. So there's a lot of reasons for doing all of this. I'm not going to talk about all of those here today, but just my recommendation. So in your examination findings, we're going to focus on a few things. We need to differentially diagnose. Now the big one is going to be sprain versus strain. Everybody uses sprain versus strain. In ICD-10, it has gotten very specific. You've got sprains and strains of pretty much everything. The extremities have their own set of codes, as well as laterality. Got a lot of choices here. Range of motion, that's always good for differentially diagnosing. Palpation, you can also use that. So here's a few things that you can apply directly into your practice. I'm going to give you one orthopedic test here in just a second, but I just want to tell you that when you do your exams and we're trying to differentially diagnose sprain versus strain, orthopedic test is probably the easiest way to do it. The primary goal is to compress or stretch pain-producing structures. Prior to doing any of this, again, you've got an acute traumatically injured patient, mostly in PI, it's to the head and to the neck, and I think we all could agree that there's some sensitive structures in there that we probably want to be cautious. I want you to rule out all contraindications to doing any of these procedures prior to doing, obviously, any compressing or stretching of the patient's head, their neck, or any area that may have been injured. You'll need to do enough of these orthopedic or provocative tests to make a differential diagnosis. Is it sprain? Is it strain? Is it something else? Some doctors ask me, well, how many of these do I have to do? Can I do just one test and then I can come up with my 20 diagnoses? Well, one test may not be enough. You may actually have to do a few more than one. The test that I would like you to think about is called O'Donoghue maneuver, and it's just one. I'm going to talk about another one here. Some of you, this may be new to you, some of you may do it already, but this one is designed to differentiate sprain versus strain, and it can be done on any joint in the body, but we're going to talk about the cervical spine, since that's what we're trying to get to is a cervical sprain strain diagnosis, or either or. So the patient is seated and we put him through some maneuvers here. First, the cervical spine is actively moved through resisted range of motion. So we're resisting their motion in all planes, all 6 planes: flexion, extension, right and left, lateral flexion, and rotation. If the patient has pain with these maneuvers, what are we doing? So we're asking these muscles to contract. So if they have pain with that, then that would be indicative of a strain diagnosis. After that, we then put them through passive range of motion, and then we evaluate if they have any pain. So as I just said, pain precipitated by isometric contraction is indicative of a cervical strain, and pain during passive motion indicative of a cervical sprain. So make sure you're very comfortable with this test. Now, the level of documentation also is going to be important. It's one thing to do the test. Now, how do we get it into our records to support whether it's a sprain or strain? And again, this can be done on any joint of the body. So here you go. O'Donoghue maneuver was positive, indicative of a strain of the cervical spine, or positive, indicative of a sprain of the cervical spine. Now, if you really want to get good and you want to raise your documentation to another level, you can put in the actual planes of movement that were where the patient had the pain. So it could be O'Donoghue maneuver was positive in flexion, right rotation, and right lateral flexion, indicative of a strain of the cervical spine. And you can do the same thing for the sprain, whichever planes of movement. Now, why is this good to put that level of documentation in there? Because when you go back and do your re-exam in about 3 or 4 weeks, you can show improvement. Maybe now the patient only has pain in flexion, and right rotation and right lateral flexion have cleared up. Insurance carriers do want to pay for patient improvement, that your care actually has to do something. And what better way to show that it's improving by increasing the level of your detailed documentation initially, and then you can show it on your re-exams. So I would highly recommend that you practice this, make sure that you're competent, and again, that you've ruled out all contraindications to doing these types of tests on your acute traumatically injured patients. The other test I would recommend is some sort of compression test, and here I'm just showing you foraminal compression test, or as it says there, other compression type tests. What I want you to focus on here is for a collapse sign, watching for what we call a collapse. We've all seen it in clinical practice, right? So what's a collapse sign? You're compressing, you're doing foraminal compression, Jackson compression, whatever you want to call it. And when you're pushing down, the patient moves away or physically kind of buckles under there because of the pain. That's a collapse sign. We've all seen it, but you want to document it because it is there in a grade 2 capsular, notice the word, sprain. I realize everybody out there is going to want to get to a sprain diagnosis, right? Because obviously more treatment, but not everybody's going to have a sprain. So you want to try and do these tests and see if you can identify that sprain. Also, you may have radicular complaints when you do this kind of compression testing. Also, note those radicular complaints in there. So your documentation would look something like this. Foraminal compression test was positive on the right with collapse sign and radicular complaints, obviously, if they were there, indicative of a cervical sprain injury. Now, there's other ways to document sprain. You can gently tap the with the patient prone. You can have them flex as much as they can, chin to chest, and then gently tap with a Babinski hammer the interspinous areas, noting pain. That's a little bit more subjective because we're trying to, get the patient's response there, but that's another way. There's a lot of different ways to get to that sprain. I would try and do as many of these as possible. Now, Jeremy, can we ask that next question in there, what they find? Yeah. You guys take a quick second here and just let me know, what do you find the most confusing, frustrating, or aggravating, or all three things about personal injury? What keeps you up at night? What really bothers you about personal injuries specifically? Just take a quick second and kind of give me the thing that pops into your head, first thing that pops into your head.
And Scott, since this one takes a few moments for folks to enter in, I'm going to just mention here, we're getting a lot of good questions. Some of them are in the Q&A pods and some of them are in the chat. The best way to get your question submitted is actually to put it in the chat pod. Rather to put it in the QA pod above the chat. So I'm kind of keeping a tabulation of those, and we'll try and get to those toward the end. But keep in mind that for actual questions to be submitted at the end of the event, make sure to put those in the Q&A pod.
I'm going to leave that up to you, Jeremy, because I see a lot of things going on my screen.
Yeah, for sure. There are some questions. In fact, while we're waiting for folks to enter in a couple things, let me just mention, I know that there are a lot of questions here about codes. Which codes are used for vertebral subluxation or segmental dysfunction, or conian cold laser is a question that we got. Lots of that stuff. I know, Scott, that is your specialty. Kind of in general at AIPIP, I'm not sure that we're going to be able to answer a lot of questions of those kinds today, but there is a couple of questions that are pertinent to ICD 9 and 10 that we'll get to at the end here. But just wanted to mention that lots of interest out there in coding. So in the meantime, it looks like we've got some pretty good answers to our poll here.
Okay, and it looks like the biggest. So a lot of people just don't want to screw up the cases, supporting treatment. Yeah, well, that's good. Got attorney issues. Yeah, personal injury. You got a lot of moving pieces, and I feel your feel your pain out there, finding a bulletproof causation statement. It can't be argued. Attorneys drastically cut your bill. You know, these are all good questions. Some of them are not simple answers. USA, I won't say the rest of it. A particular carrier that starts with U and ends with A issues, and has the S and an A in the middle. Yeah, so yeah, personal injury can be confusing and frustrating because, as you know, none of you were taught anything about personal injury in your professional training. So where do you learn it? You pick it up. Once you graduate, maybe you do it on your own, which costs you thousands, and sometimes I don't even want to make you sick, but hundreds of thousands of dollars over the course of your career, right? Because you know you get asked for drastic reductions, or you don't get paid, or patients run off with the check, or you name it, or even worse, where the big miss is you know everyone's focused on their current cases. The biggest problem for providers that'll make you sick is the cases that you're never going to get, the referrals that you are not going to get because people that could refer to your office just don't, whether it's internal or external. And you know, part of what we do at AIPIP is make you marketable and help you with your personal injury practice, so you can get referrals, because believe it or not, there are people out there that are looking to refer to competent treating doctors that will take the time to understand personal injury. And so that's a whole market out there that for many of you, you just haven't tapped into it yet. But if you think about how many cases you didn't get, as opposed to just the ones that you're having problems with, that'll make you even more sick to your stomach. All right. So ranges of motion is another way to document sprain versus strain. Just to give you some ideas here, visual is probably the most common, but really it's inaccurate. If you're going to do visual, you see there in check mark number 3, I don't recommend that you document specific degrees, document restrictions or decrease, because if you're documenting visually and somebody bends their head forward, how many degrees is it? Basically, you're swagging it, right? So swag stands for a scientific wild-ass guess. And in this type of work, if you're ever in a deposition or your case goes down the process of going to court, that's an easy, and you know, they see that in your records, that is so easy to just make you look foolish by putting in, doc, how do you know it's 35 degrees flexion? How could it be 36? Of course you're going to have to answer yes. I mean, why even put yourself in that position? That's, again, part of what we do is protect the doctors from themselves. Range of motion inclinometry, and especially computerized inclinometry, is the best. It's reproducible, has the best inter-examiner reliability, and note there under it says, note the area of pain and type of pain, because this can support your sprain versus strain. Different types of pain indicate different tissues that are involved. If someone has a sharp stabbing pain, then that may be indicative of a joint or ligamentous injury, therefore a sprain. If it's a pulling, a dull, an achy, or a stiff, it may be indicative more of a strain. But so many providers don't take that extra step, and I'll just keep hitting you with it. ICD-10, you gotta focus on details. You can't let this slide. I mean, you're gonna leave yourself so vulnerable. And as frustrating and aggravating as you think personal injury is now, just imagine when your cases start to get scrutinized even more. You're going to run for the hills, and there's no need for it. That's the point. There's no need for it. Palpation, inflammation, muscle spasms, edema, all of these are, you know, muscle spasms obviously of a strain injury, edema, inflammation. These are all things that you can document. We're focusing more on objective findings, trigger points. Muscle hypertonicity, you notice subluxation at the very bottom and in a different size font, not really the most inter-examiner reliability, objective finding, you could hang your hat on. The other thing I want you to focus on in personal injury, not only sprain versus strain, is demonstrable injuries. Personal injury is about what you can demonstrate, document and demonstrate. Bruises, burns, visible inflammation, swelling and edema, lacerations, all of these have value in personal injury. It's our job as the physician to go ahead and document those. So many providers will tell me, it's not my job. My job is just to treat. Well, speak to any of the attorneys that you work with, and they'll tell you your job is to be a patient advocate and to understand, identify, document, and demonstrate so they can get their client fairly compensated. If that's not something that you want to do, then personal injury is probably not for you, or will continue to be aggravating and frustrating. Diagnostic imaging, got a lot of demonstrable injuries here. Also, we can document some of our diagnoses off of this as well. Our disc issues, our ligamentous laxity on digital motion, torn rotator cuff, slap lesions on MRA, MRI, disc issues. In ICD10, each disc condition has been broken down now into levels. So you have upper, mid, and lower, for example, cervical disc issues. All these are supporting your diagnosis. You have a disc diagnosis, changes your treatment. So I would recommend that you think about diagnostic imaging. Also, demonstrable injuries, lost range of motion, especially with the computerized range of motion. Lost range of motion is a value driver. So what's a value driver? Well, it's exactly what it sounds like. It increases the value of a case when it is there and documented appropriately. Again, it's objective, used in the AMA guides. When it's computerized, you can't fudge the numbers, and that's the benefit of having a computerized evaluation inclinometer to not only support your diagnoses, but to also increase and have value drivers. So many of you out there, part of what you wrote in before was I get asked to reduce my bills, or I get asked for ridiculous reductions in my bills. As I said, there's a reason for that. Sometimes, as providers, we're not giving the people that are trying to settle our cases as much ammo in order to get a fair value settlement. And so they have to ask us for reductions. It's not always our fault. I'm not saying that it is, but we can control what we can control. We can't control the patient or the attorney or the insurance carriers, but let's do the best that we can do to get that. And muscle testing. Muscle testing is also weakness, so it's a value driver. They may also have radicular symptoms associated with that, which is another value driver, another reason why we want to use something objective. Can't fudge the numbers, can't do a lot of things when it's computerized. It goes right in there, and we can't touch anything. All right, for those of you that have been falling asleep and drooling on your keyboards, this is the time to wake up, because we are going to go through an example case here, and we're also going to give you some sample potential diagnoses for that case. Hey, Jeremy, if we can ask that last question here while people are kind of waking up. And so take a quick second, and what's the one thing you'd like to improve about your personal injury practice? Take a quick second. Now we're going to go through an example. Got a lot of good stuff coming in. You guys are pretty much, yeah, I see. Yep, everybody's on the same page. Daily soap notes, documentation, attorney relationships, expertise, skill, efficiency, decreasing insurance denials. Yeah. Okay, cool. What we do at AIPIP comes down to three things. Make more, get more in less time. Three things in personal injury. And that would be able to help with your documentation, your attorney relationships, your insurance denials. What you want to do with your documentation is the insurance carriers are going to look at it anyway, but at least make it look like you know what you're doing, because this way they'll move on to the next person. You follow what I'm saying? So they look at everything, and even if the provider looks like they know what's going on, there's so many other providers that have no clue, and especially, as I mentioned earlier, the ones that don't do a lot of PI, and those are the easier ones to go after. All right, so let's look at an example. Now, of course, this is not the level of documentation that I am recommending. I am just pulling or extracting out certain history issues here to ultimately lead to our diagnosis. So this is, I'm not saying this is a complete history by any stretch of the imagination, but the driver of a vehicle is involved in a motor vehicle crash or collision with an SUV. In ICD-10, the reason why I use SUV is because those E codes are now much more specific. They do talk about pickup truck, car, SUV, so they break it down to the type of vehicle. That's why I put that there. Again, a level of detail your documentation may not have had before. So patients complain severe neck and right shoulder pain. They have headaches, they have severe lower back pain, left knee pain, irritability, anxiety, and visible knee bruising. Those are just a synopsis of the patient complaints. We get into our exam. These are the highlights of the examination. The patient has restricted cervical range of motion, all planes. Notice the level of documentation right there with sharp endpoint pain. Okay, notice that. We also have a positive right empty can and supraspinatus press test for the shoulder with shoulder pain and a mild weakness. The next one, right foraminal compression test. Notice with what? Collapse sign. What does that support? Our sprain. Positive O'Donoghue's maneuver in active bilateral cervical spine rotation. Okay, so we got O'Donoghue's in there. We have decreased sensation to pin on our neuro exam. All the other neuros that we did were within normal limits, so I'm not going to go in there and put them all in there for you. Cervical paraspinal, upper trapezius, and middle trapezius muscle spasms. Okay, and lumbosacral tenderness. Now pay attention to those. Those are, I put the words in there very specifically for a reason. We have positive left knee patellar ballottement and McMurray's. We have visible swelling and bruising of the left knee. You see this all day long. You treat any personal injury patients, your patients probably have about 80% of what I put on there. Some of them may actually have all of them. So this is a very standard case. Now, based on our history, based on our subjective complaints, based on our objective findings on physical examination, what can we support related to our diagnosis, right? Or what can we potentially diagnose? Well, sprain, we did enough in there, right? We did have the sharp endpoint and we had the collapse sign. So we had enough in there to support our sprain of the cervical spine. Notice the letter A at the end there. And this was a question that I did see, that these S codes right here, anytime there's an S code, it requires a seventh digit. So A stands for the initial encounter. So S code requires a seventh digit. Now the code by itself is actually S13.4. If you think back to our first few slides, I told you that ICD-10 had what are called dummy placeholders. Well, we can't automatically jump from the 4 to the letter A. That would only be 5, right? 5 digits. So in order to get to 7, we use X's, the letter X, capital X, as dummy placeholders. So we need 2 of them to get to that initial encounter, which is A. You also have D, which is subsequent encounter, and S, which is sequela. Sequela, in my opinion, That would be a follow-up if somebody had a burn or a laceration and needed maybe some sort of scar reduction or some sort of procedure down the road. From the type of providers that I believe are on this webinar, the S code at the end is probably something right here on the 7th digit that you're not going to use. The D for subsequent would be used if you've actually released the patient from their motor vehicle and they come back. So essentially, you just keep that A on there the entire time they're under active care. Only if you've released them, and we always have patients that do come back, and they may come back, that would we now append a D on there. We also have enough to document a strain of the muscles of the neck. Notice I put a strain of the lower back. There wasn't enough supporting documentation for a sprain. That's why I drew your attention to lumbosacral tenderness. We had muscle spasms. We had paresthesia based on our neurological testing. We had effusion and contusion based on the visible swelling and bruising. We also, from our shoulder testing, had a strain, the S code here. Notice again, that code requires the 7th digit, so there's the A. Irritability and anger was something that the patient had subjectively told us. Notice it doesn't require any other digits, doesn't require dummy placeholders or anything. That's the code right there. So your S codes and your V codes, which are your external cause codes, will require that 7th digit. You have traumatic headaches. Notice here again, your V code does require a 7th digit. And in this case, we only have one dummy placeholder, that X right there. And then we can get to the A. But notice the description, car driver injured in collision with what? SUV. That's why in my history, I got specific and mentioned that the vehicle was an SUV in traffic accident. All right. Hopefully that made some sense. This is our website at AIPIP. If you go to our homepage at AIPIP.com, over here, if you want one simple step to improve your personal injury outcomes immediately, I have a short video on what you can do, a very simple and easy step to improve your outcomes. Also, if you're interested in kind of what we do, we have a free trial membership over on the left-hand side in this red box right here where it says membership. You would click on that. It would take you to this screen right here. You click on this big red box where you can't miss. It says free trial. Put in your information. It'll give you at least a little taste access to what we do, a 2-week trial to some of what we do and how we work with providers in personal injury. I'm going to open it up to questions. So Jeremy, if you want to let me see some of these.
Yeah, for sure. So I've sent a few over to you. I just wanted to comment on a few kind of last-minute house cleaning items here. So like I said, a lot of the questions that we got a ton of questions, Scott, about coding. Like I said, I don't know that we're going to have time right now to go over all of the coding questions, but I believe that you probably field those kinds of things on a regular basis, I assume. So Scott and, of course, JTech here will be happy to address any questions that we don't get to. I know we are running short on time. Stick with us for just a couple of minutes because we do have a couple of really good Q&A questions that came through. One of which I kind of want to address here just generally because I think it'll be good for clarification. Is everything you're presenting today true for all states? I practice in, well, this person practiced in Oregon, but we've had people from Oregon, we've had people from New York, just kind of all over, and I wonder what is the applicability of the material today to different regions?
Yep, it applies to all states, just like ICD10 applied to all states. It wasn't state-specific, was it? So ICD10 will be exactly the same thing. It will apply to all states. Now, there are some states that those E codes are mandatory. So those are ones that there's no national standard for those E codes or now the V codes that you saw there, but the states that are mandatory, which is Arizona, California, Minnesota, Utah, Washington, and Wisconsin, do require the use of V codes. That's a state mandate. There is no national mandate on that. So if you're in one of those states, you definitely want to use the V codes, and they use that for reporting purposes.
Okay. More coding questions coming through, so I think we need to address this. There was one question. Unfortunately, we don't have the time to go through all of the individual codes for all kinds of procedures today, but here's a question that I think is kind of a useful guidepost here. With ICD10, they gave us a particular code that was used for cervical and lumbar restriction and stiffness. What have you been recommending for the equivalent in ICD10? I wonder, just in general, what method do you recommend, Scott, for making that coding transition from ICD9 to 10? I know you talked about the website earlier with from the CMS and those kinds of things. Just generally, how would you approach that?
How do you approach it? Well, they do have ways that you can put in an ICD-9 and come up with an ICD-10 equivalent code for that. As far as stiffness is concerned, the stiffness code is M25.6. Now it relates to a lot of the extremities, and then from there you'd get more specific. So the base code, if you will, is M25.6. If you're talking about the spine, there really isn't one, so you would use M25.60, which is stiffness, unspecified joint, not elsewhere classified, or NEC is what they call it. So that's the old stiffness code that went to the M25.6.
All right, let's try and squeeze in a few quick ones if we can here. So I've had a few questions about recruitment. One person had asked whether there is a statute of limitations on recruitment, and then we actually have another question that just came in through the chat also about recruitment. When is the recruitment going to begin?
Well, it's recoupment, and it's already there. I mean, it happened to you, but insurance carriers are, here's my point, is insurance carriers are already doing it. So with the lack of specificity in your claims, you just allow that window and that door to be open even more for recoupment. Now, most insurance carriers don't go back more than 2 years, but within that 2 years, say for example you're treating a number of patients from a specific carrier, in 2 years you could treat 10 of those. And they decide one day to send you a letter and saying, hey, you know what? We want to take a closer look at your documentation. We got your, we paid these claims. We paid PIP. We paid you. But now send us your documentation, and we need to take a closer look, and we're going to send them out. That's why I'm telling you to make sure that your documentation is good now, because you don't know, and B, they go back a while, and C, it could be a large pool of patients. And it's happening now. It's not as if this is theoretical. It happens already. Yeah. Hopefully that answered the questions.
Yep. Let's try and call it back just before we wrap up here to some of the concerns that people had expressed in the earlier poll about the biggest frustrations. We both saw, everybody in the room saw that a lot of that had to do with documentation, with best practices for assessments and evaluation. We've had a few questions come in through the Q&A pod about the fastest method to document PI. They say that 90% of your suggestions they've been implementing. It just takes a lot of time. I know that you probably have some good answers to that. I'm just going to mention here, just very briefly, we also have questions about computerized inclinometers, that, of course, JTech, we have a reason why we've co-hosted this with AIPIP, because we specialize in documentation systems and physical assessments. So, of course, we have some guidance on that as well, but Scott, I don't know if you had a particular viewpoint on that.
Yeah, I mean, here's my take when it comes to personal injury, because again, we go back to all your records are scrutinized. The more objective documentation you have, which does include restricted range of motion, computerized, not visual, but visual is an okay initial evaluation. But if you're going to really document it correctly, and it's also a value driver, yes, you want more objective findings. So range of motion and muscle testing and maybe your x-ray. the more objective you can have in your notes, the more you substantiate your treatment. The more things that you put in your records that you think are objective, like palpation, after a period of time, if you're on visit number 25 and your whole support of your treatment is based on palpation, you're kind of scraping the bottom of the barrel there, you know. So I would focus more on what you can do to objectively document and support your treatment. Now, the fastest way is what you asked me earlier, right? The fastest way to document PI is to dictate. That's it, dictate. But you have to know exactly what to do and what to say. That's the fastest way. You can dictate a high-quality personal injury note in about 1 minute, because you can speak faster than you can write or click a bunch of buttons. And as I mentioned earlier, clicking a bunch of buttons doesn't save you. I would like to just mention that JTech does have some training seminars coming up, so if you are interested in this, I would highly recommend looking into this. They're going to be actually over here in Arizona in Phoenix later on this month. In November, they're going to be in New York. Contact them for the specific dates. In January, it's going to be in Salt Lake City, and they have other seminars that they're planning right now for 2016. But the training and certification that they offer is definitely needed to objectify and use to demonstrate injuries in personal injury, and it will only help protect you and improve your reimbursement. And I'm sure that everybody that here really values the quality, you know, the benefits of a good night's sleep. And when you have good documentation, you can sleep really well. You know, if you don't, you're going to be tossing and turning because you leave yourself open to all kinds of issues. Always has, always will.
And I'll also mention that those training events, they deal with not only documentation and the physical assessment, but functional assessment as well. And those are based on inquiries. If that's something that you're interested in, please let us know, because we pick the dates and locations for those based on who we hear from. And also I want to mention, because again, just based on the number of coding questions that we got, I'd like to just throw it back to you, Scott. If people have further questions about just physical, personal injury, practice management, those kinds of things, the best way, I think we've got here down on the bottom of our page web links to go to the AIPIP website. I don't know if you had any particular guidance for them to direct those questions to you following the event today, since we're out of time.
Yeah, I mean, if you have questions, you can send an email to info at aipip.com. Now, let me just say this. Some of the questions that you may ask can be convoluted and have a lot of variables, so they may not be able to, and I'll let you know if they can't be answered in an email, because some of the questions, sometimes in personal injury, do get complex. So there's a lot of variables. I do want to thank Dr. Zamora there. I'll just call her out for telling the Diamond membership is so worth it. Thank you, Doc. Appreciate that.
Absolutely. Absolutely.
Hey,
the important thing is just to let us know what's going on. So yeah, Scott, I know we're wrapping up. So thank you again for taking all of your time, and appreciate you staying a little bit late to answer extra questions. Again, if we didn't get to your question, we will try and follow up with you after the event. Check the web links to get out to JTech Medical or to the AIPIP group. Also a few articles there that Dr. Tauber has written recently, really good stuff about general personal injury best practices. Rules of the Road, of course, was the most recent one that he did, and that was a pretty interesting read as well. Thank you all for attending today. We appreciate you taking the time out of your day and submitting your questions and interacting with us. After the event, we will be asking you some of your thoughts on how the event went, on what other types of topics you'd like us to address for you in the future events. We'd certainly love to have you back. And other than that, Scott, again, thank you so much for taking the time today. We really appreciate it.
Yep, thank you guys, and appreciate all your work over at JTech, and thanks everybody. Very complex topic, hard to get it all in an hour, but you know.
We do what we can. Thanks so much, everybody. Take care. Have a great day.